pulmonary artery and the aorta, nothing but patent ductus arteriosus. So point number one, if I ask you, is it a right to left shunt or a right or a left to right shunt? I think hello everyone, welcome to Pediatrics by Dr. Anand. Today's topic of choice is cardiology. We are coming to the end of the cardio series. Our cardio series has been amazing and super hit. Thank you so much for all the love and support, and we are coming to the end of the session. Before starting any amazing segment, we always have a motivating quote. And today's beautiful motivating quote is, you are the writer of your own story. You are the writer of your own story. So it's nice if you write something amazing. So you are the writer of your own story. So you're the writer of your own story, so make your story amazing. Write your story, write something amazing in your life. Like, you are only answerable to yourself. My humble request is to everyone. We all are in broken relationships. We all are in broken families. Somewhere or the other, something is right and something is wrong. Someone does not have a best friend. Someone doesn't have, I wish I had a best friend. I wish I had an elder brother. I wish I had an elder sister. I wish my parents were more sensible. I wish my husband or wife were more better. Are you understanding? We all are having some category of happiness and some category of problems. I wish I had a nice school childhood. My school childhood is not great. So we all, anyone can have any other pros and cons or ups and downs or good or bad in any category segment of life. So that's what I tell everyone, that you are the writer of your own story. You are the writer of your own story. So you better write something amazing. If you're in a broken relationship, evacuate. Just get out of it. If you're in broken families, try to lead your life and try to have a vision and a path of your life. If you're in a bad friendship or a bad group of friends, then you definitely get out of it. So everything is in your hand. Okay, just don't tell this line that oh, God has done this to me. I don't know why God has done this to me. My fate only is like that. So don't blame to God or don't blame on fate. You make your own story, you make your own life, you make your own path. Be responsible. When you are responsible for being happy, be responsible for being sad, and then be responsible for doing better to avoid being sad. Okay, thank you so much. So let's start this beautiful class now. Today's topic of choice is PDA. So as everyone knows, what is PDA? I think everyone beautifully agree. PDA is nothing but patent ductus arteriosus, right? PDA is nothing but patent ductus arteriosus. So if I am a student who wants to crack a theory and a PG paper, so what all questions come to my mind? So patent ductus arteriosus. First random thing which comes to my mind, that PDA is between what and what? Can you please tell me in the comment section? What do you think? That we have the four-chambered heart, we have right atrium and right ventricle, and left atrium and left ventricle, and this one is nothing but patent ductus arteriosus, which is between the pulmonary artery and the aorta. It is between the pulmonary artery and the aorta, nothing but patent ductus arteriosus. So point number one, if I ask you, is it a right to left shunt or a right or a left to right shunt? I think everyone agrees this is a left to right shunt. Patent ductus arteriosus PDA is a left to right shunt. Means, what do you mean by left to right? I mean by left to right is that this path, this whole channel, if the blood has to flow, the blood will flow from the very importantly from the left to right, And why is like that? Can anyone tell me why it is like that? Because the left side of the heart has a higher pressure and a higher musculature. So if the shunt has to open, it will be from the left to right. Number one, so PDA is a left to right shunt. Number two, is it a cyanotic congenital heart or a cyanotic congenital heart? So very beautiful. The answer is, it is a cyanotic congenital heart disease, because as everyone beautifully knows that where this blood is going, when the blood is going from the left side to the right side and then to the pulmonary artery, and pulmonary artery is connected to the lungs. Basically, pulmonary artery are connected to the lungs for the purification of blood. So whenever in any chamber where the lungs are available for the purification, of the blood, that will be a cyanotic congenital heart disease. That is why atrial septal defect ventricular septal defect, and patent ductus arteriosus. These all are beautifully left to right shunts. These all are acyanotic congenital heart disease. Very important. But are you understanding? Because the blood is going to the pulmonary artery, and pulmonary artery are connected into the lungs. Lungs function is for the lungs. The function of the lungs are purification of the blood basically. And once the blood is purified, the congenital heart will be acyanotic. Acyanotic. That is. Okay, so the first thing which comes to my mind is patent ductus arteriosus is between what and what. Just now I told you. Now, very importantly, this point is important. I told you this patent ductus arteriosus, it is between the pulmonary artery and the aorta, but the more beautiful answer will be descending aorta. The more better answer will be descending aorta. So please remember, patent ductus arteriosus is between the pulmonary artery and descending aorta, not arch of aorta, not ascending aorta, descending aorta, descending aorta. So patent ductus arteriosus is between the pulmonary artery and descending aorta. Number one, that is the first thing. So among these four options, the option number one has the best answer. It is between the pulmonary artery and the descending aorta. Number one. Okay, number two, very importantly, we must understand. I'll show this picture also is very nice. If you can see this whole thing is the aorta. Okay, this whole thing is the aorta, and this one is the pulmonary artery. This thing is the pulmonary artery. Aorta gives a branch of right brachiocephalic trunk and a left brachiocephalic trunk. Okay, there are two branches. One is right brachiocephalic trunk and one is left brachiocephalic trunk. Left brachiocephalic trunk gives a branch of left common carotid artery and left subclavian artery. Okay, I'll repeat again. We have right brachiocephalic trunk and left brachiocephalic trunk. The left brachiocephalic trunk gives a left common carotid artery and left subclavian artery. Two important things are there. Okay, so now one very important thing, why I'm showing you this diagram, because I need to tell you one point, that ductus arteriosus, it is distal to the left subclavian artery. First understand this line, ductus arteriosus is distal to the left subclavian artery. If I show you this one, so this part, this is the ductus arteriosus number one, this is the ductus arteriosus, and this is the subclavian artery. Can you see that left subclavian artery, this one? So can you see that ductus arteriosus, it is distal like after the left subclavian artery? That's the first point. So ductus arteriosus is distal to the left subclavian artery, number one, very importantly. But how much distal? Now this is an exam question, that ductus arteriosus is how much distal to the left subclavian artery. So the beautiful answer we have is, very importantly, yes, it is 5 to 10 millimeter distal. It is 5 to 10, it is 5, very importantly, 5 to 10 mm distal to the left subclavian artery. This is a very important exam question. Okay. Yeah, so ductus arteriosus is 5 to 10 millimeter distal to the left subclavian artery, and ductus enters the pulmonary artery at its bifurcation. Ductus enters the pulmonary artery at its bifurcation. Now, see this line. Can we appreciate this line? 1 second, I'll draw it again. So it's saying ductus enters. Ductus, this is the ductus, right? It enters. Are you understanding why it's saying it enters? Because I am saying it is a left to right shunt. Are you understanding? The direction of the blood flow is like the ductus is entering the pulmonary artery. Are you understanding? Yes or no? Ductus arteriosus in the fetal circulation, it is right to left shunt, but once the baby is out, the ductus arteriosus is a left to right shunt. So that's what the line was saying, that ductus, this is the ductus arteriosus. So ductus arteriosus enters the pulmonary artery. Basically, where does it enter? What was the line? Yeah, ductus enters the pulmonary artery at its bifurcation. So that's which is the bifurcation? This one only. No, this is one bifurcation, this is the second bifurcation. So at the bifurcation itself, our ductus arteriosus is entering the pulmonary artery. So ductus arteriosus is entering the pulmonary artery at its bifurcation. This is one line we are able to appreciate. Okay, I hope you have got it. Okay, I'm trying my best to teach you in as amazing way as possible. If my speed is very fast, then you can put this video on the 0.5x, and if you're revising it, then put it on 1.5x. Okay. Yeah. What are the factors causing the closure of patent ductus arteriosus? This is also a very beautiful question. If I make the four-chambered heart very beautifully, and also I understand this one, what we called, yeah, this one. Yes, if this is the patent ductus arteriosus, what are the factors causing closure of the PDA? What are the factors causing closure of the patent ductus arteriosus? So as I told you, very importantly, once the baby is born, what are the important things? Placenta gets cut. Do you agree with this? Yes or no? Once the baby is born, placenta gets cut. Normally, placenta secretes PGE2. Very importantly, placenta secretes PGE2, which basically helps in keeping the ductus arteriosus open. This is normal. But placenta normally secretes PGE2, which helps in keeping the ductus arteriosus open. Once the placenta is cut, PGE2 levels go down and ductus arteriosus close. This is one important factor which is helpful in closure of the patent ductus arteriosus. Number one. Number two, very important. Once the baby is born again, then the lungs basically. Once the baby is born, the lungs basically, the lungs are functioning, right? Lungs are positively working, right? And once the lungs are working, nothing but oxygen that is going inside and outside in the lungs basically, and oxygen is a very good smooth muscle constrictor. Oxygen is a good smooth muscle constrictor. Remember that, okay? Oxygen is a good smooth muscle constrictor. That you should know. Okay, I hope you're getting it. So the factors important for the closure of PDA are, of course, unavailability of the placenta. Lungs basically are starting functioning now, very importantly. This is one important thing. And but the other factors, so in some book says bradykinin also. Bradykinin is a smooth muscle constrictor that also helps in the closure of PDA. Okay, so the important things are, we have oxygen, which I told you, bradykinin, which I have told you, and also catecholamines and acetylcholine. These four things I want you to remember. They are the factors responsible for closure of PGA: oxygen, bradykinin, catecholamines, and acetylcholine esterase. Oxygen, bradykinin, catecholamines, and acetylcholine, and also placenta getting cut, PGE2 levels go down, ductus arteriosus closure. That's all you should know. Incidence of PDA is more common in males or females. In general, patent ductus arteriosus is more common in the females, baby. It is 1:2. So there are double ratio chances are there for female having PDA. PDA is common in females, and also the question was, PDA is common in patients staying in low altitude or high altitude. Babies who are born in very high altitude deliveries on a very hilly areas, their PDA opening, keeping it open chances are a little high. So PDA is open in high altitude areas, that you should know. One syndrome where PDA is seen, that also very beautiful one. Do you remember one syndrome where the PDA is seen? So do you know the torch infection? Yes or no? Torch. We have T for toxoplasmosis, others rubella, cytomegalovirus, and herpes. So R for rubella, right? R for rubella. So congenital rubella syndrome or rubella infection basically has the triad of cafe coffee day. The triad is cafe coffee day. The congenital rubella syndrome has a triad of cafe coffee day. C for congenital heart disease. Then C is nothing but cataract, and D is nothing but deafness. Okay, so congenital heart disease, cataract, and deafness are basically, what you called important triad of congenital rubella syndrome. And the most common congenital heart disease in congenital rubella syndrome is nothing but patent ductus arteriosus. So PDA is connecting over here. Okay, PDA, the most common congenital heart disease in congenital rubella syndrome is patent ductus arteriosus. Patent ductus arteriosus, that you should know. Okay, so PDA is one thing I want you guys to remember. PDA. Okay. Okay, this part is done. Congenital rubella over. Acha. Now the one very important thing, very nice, I want to share this information. Please read this line. It is important to realize that PGA in term babies is a structural abnormality, but in preterms it is a physiological developmental problem. Like, understand this line. This line is really beautiful, my dear friends. It says it is important to realize that PGA in term babies is a structural abnormality. I hope you know that. For closing of PDA, if I want to close the PDA, can anyone guess what do you want to give me? If you want to close the PDA, you can give me ibuprofen. Or you can give me indomethacin. Okay, you can give me ibuprofen, indomethacin, or paracetamol. These three things are available if you want to close my PTA. Okay, ibuprofen, indomethacin, and paracetamol. And best answer is ibuprofen. Everyone knows about it. This is when you want to close my PTA. Okay, but now remember one thing. Ibuprofen and indomethacin are helpful in preterm baby. Hello everyone. Now this is really important, okay? The role of ibuprofen and indomethacin is beneficial in preterm babies, very, very important. This drugs has no role in term babies. In term babies, surgery is the best option of choice. In the term baby, surgery is the best option of choice. In the preterm baby, oral medication will be comfortable, but in term baby, surgery will be the best option of choice. That is why this line is important. It is important to realize that PTA in term baby is a structural abnormality. In term baby, it is a structural abnormality and surgery is the option. But in preterm baby, it is a physiological developmental problem. That's why I'm giving these drugs to close the PTA. Okay, I hope you're getting it. Coming to the important murmurs and shunt murmur and flow murmurs in a case of PTA. See, always remember, whenever you're explaining any congenital heart disease, you have to explain about S1 heart sound, S2 heart sound, any shunt murmur, or any flow murmur. These four things you should always comment. Okay, S1, S2, shunt murmur, and a flow murmur. Now, the question number one I'm able to get it is M1. What about the M1? Is it loud or soft in the case of patent ductus arteriosus? So this is patent ductus arteriosus we're talking about, and which is M1? This M1 is the mitral valve. This is the tricuspid valve known as T1, and we has S1 is the first heart sound which is present because of the closure of the tricuspid valve and the mitral valve, right? That's what. So the first heart sound, basically it is because of the closure of the tricuspid and mitral valve. The question is, in a case of patent ductus arteriosus, what happens to the M1? Will it be loud or will it be soft? So as you all know that patent ductus arteriosus, it is a left to right, right? The direction is like this. It is a left to right shunt. So more and more blood will enter into the pulmonary artery followed by lungs, and from the lungs more and more blood will come to the left atrium and more blood will come to the left ventricle. That is why I think M1 will be loud. I think whenever there is increased blood flow towards any wall, that wall sound will be loud or a soft, depends, no? So here the more blood flow is there, M1 will be loud in a case of patent ductus arteriosus. Number one. Yeah, this part is over. Now shunt murmur, so it's a very easy one. So remember, again we have to link and study what was the shunt murmur in ASD. In a case of ASD, the shunt murmur was absent. In a case of atrial septal defect, the shunt murmur was absent. Why it was absent? As you know, if I have told you in the previous class, that we have a large ASD. Normally ASD is a large ASD. Point number one. In the atrial septal defect, usually it is a large ASD. So whatever blood is entering to the left atrium, it is directly going to the right atrium. Whatever blood is entering the left atrium, it is directly going to the right atrium. So it is a large, in a case of large ASD, the shunt murmur will be absent because the blood is not staying in the left atrium. Directly it is going into the right atrium. It's because of the large shunt, large ASD. The shunting of the blood is very fast and very easy. So that's why shunt murmur is absent in a case of what we called ASD. In a case of ventricular septal defect, you will have a pansystolic murmur. You will have a pansystolic murmur in a case of ASD, and in the case of PDA, you will have a continuous machinery murmur. You will have a continuous machinery murmur. Okay, so these three things I want you guys to remember. So very importantly, you must understand. So we have the absent ASD, the shunt murmur in a case of ASD is absent. In a case of VSD, it is pansystolic. In a case of PDA, it is continuous machinery murmur. So machinery murmur is something which is important in a case of ASD. Okay, what will happen to S2 in a case of large PDA? Again, a very beautiful question. What will happen to the second heart sound in a case of large PDA? Second heart sound, large PDA. So S2, second heart sound is because of the closure of the pulmonary valves, which is known as P2, and aortic valve, nothing known as A2. Normally, you know that, right? The A2 closes early than P2. See, listen very carefully. The second heart sound is because of the closure of the pulmonary valves and the aortic valves. But in general, A2 little bit, slightly it closes early than the P2, because P2, no, it has the right side of the heart has to do a lot of work. The right side of the heart has superior vena cava, inferior vena cava, the blood entering the right atrium, right ventricle. So basically, right side of the heart has to do a lot of work, extra work. That is why, like this, what you call aortic component will close early than the pulmonary component. Aortic component will close early than the pulmonary component. This is normal. This is normal, what you call normally seen in a case of S2 in normal people. Whereas in a case of large PDA, what will happen to the S2 heart sound? Remember, P for PDA, P for paradoxical split of S2. P for PDA, P for paradoxical split of S2. There will be paradoxical split of S2 in a case of PDA. Paradoxical as an opposite, as an opposite. Normally, A2 closes early than P2, but in a case of large PDA, remember P2 will close early than A2. Okay, normally A2 closes early than P2 because I told you the right side of the heart has to do a lot of work. So pulmonary component will take little time to close. So A2 will close early than P2 normally, whereas in a case of large PDA, P2 will close more early than the A2. Number one. Number two, why this is happening? In a case of large PDAs, you know that PDA is a left to right shunt. Okay, large PDA. So when the blood goes from left to right, there will be increased pulmonary blood flow. Increase pulmonary blood flow in the pulmonary artery. There will be too much of blood going, yes or no? Whenever there is increased pulmonary blood flow, slowly pulmonary artery goes into damage, known as pulmonary obstruction. I would say pulmonary obstruction. Okay. So once there is slowly, when there is too much of traffic on a road, the road starts to damage. So there will be pulmonary obstruction, and because of the pulmonary obstruction, the shunt which was left to right, the blood was going from left to right. No, now there is pulmonary obstruction. So now the blood will go from right to left. Are you understanding? So there is pulmonary obstruction, or nothing but pulmonary obstruction, nothing but our P2 basically is closing early than the A2. Now this is what is the paradoxical split in a case of large PDA. Are you understanding? I'll repeat again. Normally A2 closes early than the P2. This is normal. But in the case of large PDA, P2 is closing early than A2. Why? Because when there is too much of pulmonary blood flow, too much of left to right shunt, because of the increased pulmonary blood flow, there is pulmonary obstruction or pulmonary stenosis or pulmonary obstruction basically. And whenever there is a pulmonary obstruction, the P2 now is closing early than the A2. This is known as paradoxical. Paradoxical means opposite, paradoxical split of S2. That you should know. This part is over. I've told you everything. Yes. Yeah, so shunt murmur and flow. So we have done a lot of stuff. Okay, okay, let's revise. In a case of patent ductus arteriosus, if I talk about the first heart sound, I understood that that M1 will be loud. If I talk about the second heart sound, I understood that the P2 will close now early than the A2 basically. That is nothing but paradoxical split. So S1, S2 over. Then we have and shunt murmur and flow murmur. Shunt murmur in a case of patent ductus arteriosus is the continuous machinery murmur. Now flow murmur. Flow as in flow murmur, again the problem will be there at the mitral wall and at the aortic wall. Mitral wall and the aortic wall. At the mitral wall it will be a delayed diastolic murmur, and aortic wall it will be an ejection systolic murmur. This also I want you guys to update in your notes. Okay, in the flow murmur in a case of PDA will be delayed diastolic. It's very easy. Understand the concept. Okay, delayed diastole, when there is so much of blood going from left side of the heart to the right side, and more basically blood going into the pulmonary artery. Pulmonary artery is connected to the lungs, and lungs left at the whole, so much of extra blood is going to the left side of the heart. So now what will happen? This is the mitral wall. No, that's why when too much of blood is going into the left atrium and left ventricle, so basically the mitral wall, there'll be delay in that diastole. You know, systole is a contraction and diastole is relaxation. When so much of blood, the left atrium, the mitral wall has to push, because naturally too much of blood is coming from the lungs. So the diastole, the relaxation of the heart, will be little delayed because it has to do a lot of work. That's why. So delay in the diastole, relaxation of the heart will little delayed because it has a lot of blood to push. That's why. So delayed diastolic murmur will be seen in a case of it's a flow murmur seen in a case at the mitral area, and the aortic area it will be a ejection systolic murmur. That you should know. Okay. Yeah, this I have told you very beautifully. So S2 heart, can we link and study? So these are the three important linking points and study that in a case of atrial septal defect, ASD, the second heart sound, you will see a wide fixed split of S2. In a case of VSD, you will see variable split of S2. And in a case of PDA, you will see paradoxical split of S2. Paradoxical. How will I remember? P for PDA, P for paradoxical, V for VSD, V for variable. Remember, V for VSD, V for variable split of S2, and P for PDA, P for paradoxical split of S2. This is really very important. Remember, okay. So this is the first half. This is the first half segment of PDA, explaining in detail and depth that what is the important function, how the PDA works. And in the second half, we're going to talk about the clinical features, investigations, and management of patent ductus arteriosus. Every video has been made with a lot of love and respect, so try to show some love and care to this video. Try to understand the concept, and if you still have any doubt, my mobile number is 9999897081. Please do let me know how are you liking the classes, the videos, are you able to understand, and I will put you in our WhatsApp and Telegram regular one-liners group. It will be easy for you. And before leaving, we always have a motivating quote, and today's quote is, yesterday you said tomorrow. Yesterday you said tomorrow. So whenever you are planning to study, planning to work hard, start from day one, start from right now. At least this topic, read in such beautiful way that you don't leave anything. So yesterday you said I'll try tomorrow. Yesterday you said I will try tomorrow. So don't wait for tomorrow. Start from today and start from right now. Thank you so much, everyone. Please take care and have a wonderful evening ahead. Welcome to Pediatrics by Dr. Anand. Today's topic of choice is pediatric cardiology, and we're going to continue the beautiful topic of patent ductus arteriosus. Before starting any amazing segment, we always have a motivating quote, and today's quote is, I have stopped explaining myself when I realized people only understand their level of perception. Very beautiful quote. I have stopped explaining myself when I realize people only understand their level of perception. So see, you don't have to prove anything to anyone. If you are right in any way, the one who understands you, the one who genuinely connects with you on emotional and mental level, they will understand you even though you explain them or you don't explain them. Because if you start explaining, they will only understand their level of perception. They will only understand what they think is right. Okay, so I have stopped explaining myself when I realize people only understand their level of perception. So the moral of the story is, you be on your own, you be amazing, you relax, you chill, just be the way you are and just live life and be happy. That's it. Zindagi भगवान की एक बहुत महंगी gift है. Life is the most expensive gift God can give you. So appreciate it, enrich it, and embrace it, and be happy about it. Just be happy for no reason. If you're happy for no reason, you are amazing. You know, just you're living, just this evening is beautiful. Just be happy for just for no reason, and life will make sense much better. If you start finding reason to be happy, that do something for me, then I will be happy. Okay, take me for a movie, then I'll be happy. Take me to France, then I'll be happy. No, you don't have to do that. Just be happy the way you are, and that's the most amazing thing about you. The topic of choice is PDA. We're going to talk about the continuation slides of PDA. The first question about PDA which comes to my mind is, what are the complications? What are the complications of large PDA can lead to? Large PDA. Now this is a PDA, right? This is a PDA very importantly. Something was left to right shunt, acyanotic congenital heart, yes or no? So what large PDA can lead to you very importantly? So now see, now one thing very important. So the PDA was a left to right shunt. No, just now we discussed it's a left to right shunt. And once something is a large PDA, there could be a reversal of shunt. Very importantly, the shunt which was left to right can become right to left, because of, I told you in the last class, whenever there is more left to right shunt, there will be increased pulmonary blood flow, and whenever there is increased pulmonary blood flow, then the more and more pulmonary artery will be damaged, leading to pulmonary obstruction or pulmonary stenosis. The shunt which was left to right will be right to left. Now number one, this is known as Eisenmenger syndrome. This is known as Eisenmenger syndrome. Very, very important. This is known as Eisenmengerization or Eisenmenger syndrome. So Eisenmenger syndrome is a 3 marks question for theory paper, and that's what you have to explain. The shunt which was Eisenmenger syndrome is seen in various conditions like PTA, then VSD, very less likely ASD. In ASD, you don't see reversal of shunt because ASD and pulmonary artery are very far. PD and pulmonary artery are very close together, so reversal of shunt can be seen in a case of PTA. Even in VSD also, the patients can have a reversal of shunt, but it will be a little late presentation, of course. And atrial septal defect is very, very less likely presentation for reversal of shunt or signs of failure, because atrial septal defect and pulmonary artery are very, very far. Number one. The important complication, the other thing, a large PDA can cause kidney damage, known as renal insufficiency. It can cause some stomach issue in the baby, known as necrotizing enterocolitis. It can have various issues. Now, see, now I'll tell you very nicely one by one. Okay, see, now large PDA as a complication. Number one, it can damage my kidneys, baby's kidney, known as renal insufficiency. It can damage the GIT, the stomach of a baby, and that is known as necrotizing enterocolitis. That is known as necrotizing enterocolitis. Okay, necrotizing enterocolitis. Number one. Number two, that can damage the brain of a child. Brain of a child is nothing but intraventricular hemorrhage. It can cause IVH. It can cause the damage the lungs of the child basically, and that is known as bronchopulmonary dysplasia. Bronchopulmonary dysplasia. Are you understanding? First, try to get the concept that a large PDA can damage to various organs of the body. Large PDA can damage the kidney, GIT, lungs, brain causing IVH, and the heart causing myocardial ischemia. Now the whole thing is why a large PDA can cause all these problems. A large PDA can have mixing of the blood. A large PDA can be acyanotic. A large PDA can cause increased pulmonary blood flow and lead to repeated upper respiratory tract infection, lower respiratory tract infection. Do you remember, guys? We have done this. Whenever there is increased pulmonary blood flow, then naturally lungs are affected more. When the lungs are affected too much, the patient can have lungs problem like increased upper URTI, increased LRTI, very importantly increased chances of pneumonia, increased chances of hospitalization. And because so many times I'm going to hospital, I will be a patient of not gaining weight and not gaining height, which is known as failure to thrive. This is what you in general you need to know. Now, as I told you, the large PDA can cause damage to all the organs. The question is why such a thing? Now, very importantly, now remember one thing I'll tell you. As you know, this is a four-chambered heart, and as you know that we have this one nothing but known as PDA. So this is patent ductus arteriosus, right? So now, as you all know, as you all can understand, that PDA, the blood, basically the blood which is coming from the pulmonary vein to the left atrium and then to the left ventricle and then to the aorta. Aorta supplies the blood to the whole body, obviously. Before supplying the blood to the whole body, where is the blood going? The blood is going from the aorta to the ductus arteriosus to the pulmonary artery. You know na, the ductus arteriosus is a left to right shunt, yes or no? So whole thing now the problem over here is, in the case of large PDA, the blood is not going to the aorta properly. Are you understanding? From the left atrium to left ventricle to the aorta, normally it should go to the thoracic aorta and abdominal aorta and to the whole body. But as ductus arteriosus is present and large patent ductus arteriosus is present, all the blood is kind of suctioning. The ductus arteriosus is stealing all the blood. The ductus arteriosus is stealing all the blood from the left side of the heart and it's taking to the right side. Now this is known as ductal steal phenomenon. Very beautiful point. This is known as ductal steal phenomenon. Ductus arteriosus stealing all the blood. Now this is one thing. That's why the ductus arteriosus is stealing all the blood. So the aorta, from the aorta, the blood is not able to reach properly to the kidney, known as causing acute kidney injury or renal insufficiency. The blood is not going to reaching the GIT properly, causing NEC. The blood is not reaching to the brains, causing IVH. It is not reaching to the lungs, causing BPD, bronchopulmonary dysplasia, and the blood is not reaching the heart, causing myocardial ischemia. Are you understanding? This is the whole biggest problem with the ductal steal phenomenon. Okay, this is a very important point. Okay, number one. Okay, next important point. Now, what we can understand in this one. So naturally, it will lead to all the problems. So now, due to ductal steal phenomenon, can my body compensate by increasing the stroke volume? Now I have a question. Imagine you are also sitting with me. We can understand, okay, PTA, patient ductus arteriosus, left to right shunt, ductus is stealing all the blood not going to the whole organs, causing organs hypoperfusion. So now the body has to compensate, right? The body has to compensate through any means. So the answer for this one will be, like, the question is, can they compensate by increasing the stroke volume? What is stroke volume? Can you please tell me the formula for stroke volume? So stroke volume is the volume of the blood pumped out of the left ventricle. So this is our left ventricle. So volume of the blood pumped out by the left ventricle during each systolic contraction, this is known as stroke volume. With each systolic contraction, the volume of the blood pumped out of the left ventricle. Okay, this is known as stroke volume. So that's what the question is. When the body needs, are you understanding? Because of the ductal steal phenomenon, the blood is going to the left from the left to right. So for the compensatory mechanism, my question is, can my newborn baby increase the stroke volume? Stroke volume is like through each systolic cardiac contraction, the amount of the volume of the blood pumped out of the left ventricle. So the best answer for this question is actually that the newborn cannot compensate by increasing the stroke volume. In adult patients, we have this, we can compensate if the blood is not reaching the thoracic and abdominal aorta and lower limbs properly. We can increase the cardiac contraction, nothing but the stroke volume, but that's in adults. In newborn baby, it's not possible, because newborn's baby left ventricle is very fragile. Newborn's baby, in a short line, if I talk about newborn's baby left ventricle is very fragile. You know, the increased left ventricle volume load is poorly tolerated as preterm have a poorly compliant left ventricle. The increased left ventricle volume load is poorly tolerated as preterm have poorly compliant left ventricle. This is one thing you need to understand. So that's the whole thing, is the problem. That now the question is, can they increase the stroke volume as a compensatory mechanism? Then the answer is no, they cannot increase the stroke volume, very importantly. And then how can they compensate? They can compensate by increasing the heart rate. Very, very important. Remember, okay? So the baby basically cannot increase the stroke volume because of the ductal steal phenomenon. It cannot increase the stroke volume because the left ventricle is not that strong enough to increase the stroke volume. So how to compensate this problem? This problem has been compensated by increasing the heart rate. So the first clinical feature of a patent ductus arteriosus baby will have tachycardia, unexplained tachycardia. Are you understanding? So in our NICU rounds also, preterm baby having tachycardia. What are the other features, other cause of tachycardia? Like in general, if the baby is in shock, the baby will present as tachycardia, very important. And if the baby is having fever, newborn baby having fever, the baby will have tachycardia. Many times, if it has happened in a hospital, that the warmer temperature is set to a higher level. Basically. What's the normal temperature of a newborn? That's another exam question. The normal temperature of a newborn is 36.5 to 37.5 degrees Celsius. The normal temperature of a newborn is 36.5 to 37.5 degrees Celsius. Anything more than 37.5 degrees Celsius will be fever, will be hyperthermia, and the patient will present to you as tachycardia. So tachycardia can happen in fever also, it can happen in shock also, it can happen in simple patent ductus arteriosus also. That's what. So once you have a tachycardia, can I say the patient will have a hyperdynamic circulation, like a tachycardia, because so much of heart rate will increase, the patient can have a hyperdynamic circulation. And because my heart rate is increasing so much, the patient will have a bounding pulses. Very, very beautiful exam question. When the heart rate is so much increasing, more and more blood pushing to the aorta and more extra blood jumping everywhere, so the patient will have a bounding peripheral pulses. Very, very important. Bounding. There is an exam question. A preterm baby having bounding peripheral pulses. What do you think? And by saying bounding peripheral pulses, also one point I can tell you: easily palpable dorsalis pedis artery. Easily palpable dorsalis pedis artery. Now this is also very important point. Okay, what is dorsalis pedis artery? Can anyone tell me, please? Dorsalis pedis artery is a continuation of anterior tibial artery. Dorsalis pedis artery is a continuation of anterior tibial artery. Number one. It's in the foot, okay? Anterior tibial artery continues as dorsalis pedis artery, very importantly, okay? So that's what. So easily palpable dorsalis pedis artery, bounding peripheral pulses, and tachycardia. These are the important features basically of a patent ductus arteriosus. Okay, so this is important. Okay, so the heart rate will cause all the problems: easily palpable dorsalis pedis artery, bounding peripheral pulses, hyperdynamic, precordium, wide pulse pressure. Very importantly, wide pulse pressure, and also hyperdynamic precordium. I have told you means visible pulsations in more than two rib spaces. One rib, two rib. The like this you will feel like that. Okay, so visible pulsations in more than two rib spaces. Number one, wide pulse pressure more than 25 millimeter of mercury, easily palpable dorsalis pedis artery, bounding pulses, everything you've got it. These are all the amazing clinical features of nothing but patent ductus arteriosus. Okay, patent ductus arteriosus. And now the question is, which day of life you should expect such symptoms? All this tachycardia, hyperdynamic circulation, and all that, ductal steel phenomenon, compensatory effect of tachycardia. So it's going to take little time, right? So the best answer for this question is roughly around day 3 to 4. Around day 3 to 4, you will get the symptoms of what you called for the symptoms of PDA, which day of life it should come. Day 3 to day 4 sounds a good one answer. Okay, remember. And what is the gold standard investigation of choice in a case of diagnosing PDA? So echo, the gold standard investigation of choice in nothing but the 2D echo or two-dimensional echo. Echo will tell us exactly what is going to happen in the baby. Okay, and do you want to restrict the fluids? So the answer is yes. In general, in the case of PDA, when there is increased pulmonary blood flow, lungs are like getting over congested, so you want to definitely restrict the fluid in a case of PDA in general. Like this one thought you must remember: don't over fluid. Like in a case of shock, you put the baby with fluids, right? In a case of PDA, you restrict the fluid. Remember that. Okay, that you should know. This part is over. Okay, everything is done. So what are the ECG? Now that we're coming to the end of this topic, so this topic has been beautifully covered. What are the ECG findings you see in a case of patent ductus arteriosus? So now tell me, what all limbs hypertrophy you will see? Which all ventricle will be enlarged? Will you see a right atrial hypertrophy? The answer is no. Will you see a right ventricular hypertrophy? The answer is no. As there is left to right shunt and increased pulmonary blood flow, more and more blood pushing in the pulmonary artery, you will have congestion at the left atrium. You will have congestion at the left ventricle. So left atrial hypertrophy, left ventricular hypertrophy is something on the X-ray you will surely see. And ECG, if I talk about what is this LAD? LAD is nothing but left axis deviation. LAD is nothing but left axis deviation. I told you ECG, we have two types of deviation. We have right axis deviation and left axis deviation. So basically, if the right side of the heart is getting enlarged too much, I will say ECG is having right axis deviation. Here the left side of the heart is getting congested too much, so ECG will show us a left axis deviation. Left axis deviation. So this is what is important. Left axis deviation you see in a case of ECG, in a case of PDA. That you should know. X-ray also we have done. Okay, and you know that, right? You will see basically what you call the chest X-ray will have a very important cardiomegaly with plethoric lung fields. I hope you know, we have done in the previous class, there is something known as oligemic lung fields and something known as plethoric lung fields. Plethoric lung fields is nothing but increased pulmonary blood flow. Plethoric means increase pulmonary blood flow, and oligemic means decrease pulmonary blood flow. Decrease pulmonary blood flow is nothing but oligemic fields, and increased pulmonary blood flow is nothing but plethoric lung fields condition. And increased pulmonary blood flow will be seen in the case of atrial septal defect, ventricular septal defect, patent ductus arteriosus, even a case known as supracardiac TAPVC. Supracardiac TAPVC, there also you will have increased pulmonary blood flow. So ASD, VSD, PDA, they will have plethoric lung fields. Done. Medical management, I told you indomethacin, ibuprofen, and PCM. These three options we have. Usually ibuprofen sounds a fair option. In our hospital we give ibuprofen actually. So yeah, we give ibuprofen in our hospital. And nowadays in recent update they are using paracetamol also. Like all three drugs are used, but ibuprofen is like the best safety profile they say about the ibuprofen. So three options are there: indomethacin, ibuprofen, paracetamol. I think ibuprofen sounds a fair option as compared to all the drugs. That you should know. Okay, this part is done. Achha, and one question was, one second, what are the contraindication of giving indomethacin? Like this ibuprofen or indomethacin or paracetamol you're giving, no, to close the PDA. What are the contraindication? In which condition, even though the ductus arteriosus is open, you cannot give that ibuprofen? Number one, if the patient is bleeding. If the patient has thrombocytopenia, don't give indomethacin or ibuprofen. If the patient having kidney problem, like if the patient is clinically bleeding, blood in stools, blood coming, so you don't what you call give ibuprofen or indomethacin. So thrombocytopenia, number one. Patient clinically bleeding, number two. Acute kidney injury, creatinine more than 1.6, that also you don't do. Oliguria, the patient having decreased urine output, you don't give. And patient having some brain issue, intraventricular hemorrhage, or GIT, stomach issue, necrotizing enterocolitis. So these are the conditions where you do not give what you call any drug to close the PDA. Are you understanding? For closing the PDA, you have options of ibuprofen, indomethacin, and paracetamol. But if simple thing, thrombocytopenia, clinically bleeding, kidney problem, urine problem, brains, it's very easy. Kidney, see, it's easy, kidney, brain, and what you called GIT, stomach, GIT. In the kidney, you have a creat more than 1.6, or clinically bleeding patient, or thrombocytopenia in that case. In the brain, you have intraventricular hemorrhage problem. In the stomach, you have necrotizing enterocolitis problem. And kidney, again, oliguria the patient has, urine output less than 1 ml per kg per hour. In these conditions, you will not give any drug to close the PDA. And again, a very quick quote: I know happiness is temporary. I know happiness comes for some time and then it goes. So is the sadness. So is the sadness. Okay, I'll repeat again. I know happiness is temporary, but remember, so is the sadness. Sadness also takes some time and it will go away. So if you're sad in your life, it will go. So you always remember, it is a phase. If you're sad in your life, if your sadness is increasing, it is not life, it is a phase of life. Sadness will come, but it will go. Sadness will come, but it will go. So, but the graph we need to understand, sadness will come and go, but for how long? See, I told you, there are people who take 6 months to come out of depression, and there are people who takes only 6 days to come out of depression. If you enter a one room, one person says that, oh my God, you got breakup, such a big thing happened, and the other person said that, no bro, it's okay to have breakup. What's wrong in that? Chill, okay, try to overcome yourself as fast as possible. So it's everyone's perception. Okay, someone says, acha, itni badi baat thi, oh my God, such a big thing was there. The other person was there, other person said that it is not that big thing also, it is okay. That's what, some people take 6 months to come out of it, and some people takes only 6 days. So I know happiness is temporary, so is the sadness. So is the sadness. Whenever you are sad, okay, whenever you are having breakup or sadness, I frankly tell you, go to gym or go to any outdoor activity. Go to gym or go do any outdoor activity. Why? It'll what you call release endorphins. It will release endorphins, and endorphins are the mood elevators. Endorphins are the mood elevators. That the cycle of sadness will break very fast. The cycle of sadness will break, like abruptly it will break. If you just start playing badminton, go for a running, or play a huge badminton or a very heavy outdoor sport, it will release endorphin, your sadness will break, and you will be okay ASAP. Remember that. Okay, this part is over, occurred. Okay, let me ask you. Okay, these are easy ones. Last is a surgery, of course. Surgery is the best option in a term baby. In a term baby, indomethacin and ibuprofen are not, what you called, not beneficial in a term baby. Surgery is done in a term baby. Either you can do ligation or coil embolization. Ligation or coil embolization, it is preferably done before 1 year of life. So in a term baby, surgery sounds a very good option. Okay, done. Okay, yeah, these are not that important, but remember, what are the complications of surgical closure? If you surgically close the PDA, the patient can have pneumothorax, the patient can have chylothorax, like it can affect the lungs of the baby basically, because it can cause pneumothorax, it can cause chylothorax, it can cause infections naturally, and it can cause vocal cord palsy. These are the 4 beautiful complications of the surgical closure of PDA. Naturally, if I'm closing the PDA, this one. Yeah. This one, see this one, patent ductus arteriosus. If I'm closing this channel, there was see PDA causes in left to right channel increase pulmonary blood flow and URTI, LR, upper respiratory, lower respiratory tract infections. Now I suddenly surgically close the totally block the PTA. Then in the lung, suddenly it can abruptly cause lung problem, that will be pneumothorax or chylothorax. Okay, pneumothorax, chylothorax, infection or vocal cord palsy. That you should, okay, this you should know. That's it. This part is over. We have done this. So if you want to, so there were two questions, right? I want to close the PDA. What will you give me? We have already done. You can give me ibuprofen, indomethacin, or paracetamol. Now, if I want to keep the PDA open, what will you give me? We have done this before. So we have done this before. We give me prostaglandin PGE1 analog. You will give me PGE1 analog to close the PDA, and that is nothing but, very importantly, L-prostadil. L-prostadil. L-prostadil is a PGE1 analog. Okay, prostaglandin. Remember, placenta secretes what? Placenta secretes PGE2. Placenta secretes PGE2, which keeps the ductus arteriosus open, but PGE2 is endogenous. PGE2 is endogenous, and placenta secretes PGE2, whereas PGE1 is nothing but I can give from outside. So the drug of choice will be L-prostadil. L-prostadil. If I want to keep the PTA open. Okay, that's it. That's it. That finishes this part. PGE1 L-prostadil for opening the PTA and indomethacin ibuprofen for closing the PTA. Thank you so much everyone for this wonderful participation. We are almost finishing the cardiology. All the cardiology important topics are done. They are over. Nothing much is left. Hardly some very rare miscellaneous thing is left. We have covered neonatology also. Please watch the videos very beautifully, very amazingly. My mobile number is 9999897081. You can just put me a message and I will add you in our one-liners group. And please take care of yourself. Life is beautiful. Life is amazing. Just cherish, just live, just be crazy. You know, you are the only architect of your life. So better make something nice out of it. Okay. Thank you and take care. Hello everyone, welcome to Pediatrics by Dr. Anand. Let's continue the beautiful cardiology series. We are coming to the end of the cardiology. I hope you are liking and loving the videos. Coming to the further slides, again before starting any amazing segment, we always have a motivating quote. And today's motivating quote is, the price of true inner happiness. The price of true inner happiness is zero, but the price we pay seeking it is unmeasurable. So basically, what is the moral of the story? The price of the true inner happiness is zero. So most importantly in life, try to be happy with what you have. Try to be happy with the way you are, the way you are living life. Don't copy him, don't copy her. You know, there is a saying, right, that the grass is always greener from other side. The grass is always greener from the other side. Means, you know, the story of the other person looks more amazing than our story. We think that we are only suffering in life, and see the other people, they are so happy, they have a big house, they have a big car, my god, they're so happy, and I am only suffering. So it's not like that. You know, the price of true inner happiness is zero. You don't have to, you know, you don't have to have a big car to be happy. You don't have to go to France to be happy. You can just be happy with your family. You can just be happy after doing a good workout. Maybe you can be happy after you know, going for a good walk or a good run. So anything is possible, right? It's the way you think. So the price of inner happiness is actually nothing. It is just zero. And today's topic of choice, we're going to talk about the TGA. The topic of choice will be TGA, transposition of great arteries. And before starting, there is one more beautiful MCQ I wanted to discuss with you. So the MCQ is, where to look for pre-ductal oxygen saturation in a 3-month born infant. Where to look for pre-ductal oxygen saturation in a case of PDA in a 3-minute born infant. So remember, in the previous class we spoke about PDA in depth and detail. We have discussed the PDA. I hope you remember that. So the question is, it's a very beautiful question. So this is the four-chambered heart. Very simple question. See, cardiology is like maths, okay? You will get it. It's very, very easy. So see, now I have made this beautiful diagram. We had the right atrium, the right ventricle, and left atrium and left ventricle. And what is this? This is our patent ductus arteriosus, nothing but PDA. So what is the beautiful question? The beautiful question is where to look for pre-ductal oxygen saturation. Pre-ductal. What is the meaning of pre-ductal? Means before the ductus arteriosus connection. So this part over here I'm talking, where to look for pre-ductal oxygen saturation in a PDA in a 3-minute born baby. The options are left upper limb, left lower limb, right upper limb, right lower limb, right? So what I'm asking here is before the mixing of the blood, because PDA is a left to right shunt and mixing of the blood will take place and all that. Before this mixing happens, do we have any limb? If I take the oxygen saturation, that will give me the pure oxygen saturation, or I would say pre-ductal, where the mixing has not happened. Are you understanding? So to know this beautiful point, we must appreciate this picture. So it's simple, same graph where the oxygenated blood from the lungs enter the left atrium with the help of pulmonary veins. From the left atrium it goes to the left ventricle, and from the left ventricle it goes to the aorta. Now before this beautiful mixing, there is some branch the aorta gives. Which is that branch, sir? So beautifully remember that the aorta basically it gives the brachiocephalic artery, and that gives the right subclavian artery. Now this is something you must appreciate. Pre-ductal, before the mixing, before this ductal mixing, the aorta, now this part of aorta, will it have the oxygenated blood or the mixed blood? So obviously this part has the oxygenated blood, right? Because it is just entering from the left ventricle. So this aorta basically has a branch of brachiocephalic artery which gives a right subclavian artery, and right subclavian artery supplies to the right upper limb. Okay, a right upper limb. That's why the most beautiful answer for this question will be that right upper limb will be the best saturation detector in a case of pre-ductal oxygen saturation. Are you understanding? It's such a beautiful, simple question. That's why I think right upper limb has the best answer. So where to look for pre-ductal oxygen saturation in a case of PDA in a 3 minutes born baby? So the best answer is right upper limb, and the explanation I have told you, amazing. Let's continue this beautiful talk. We're going to talk about a very important topic known as TGA, and we are coming to the end of the cardiology series. I hope you're liking the lectures. Rushkind procedure. A very beautiful question. Rushkind procedure is done in which condition? So at least two things you remember. Okay, one is known as Rushkind procedure and one is known as Norwood procedure. Rushkind procedure and Norwood procedure is two things we must appreciate. Rushkind procedure is done in a case of DTGA. DTGA is nothing but dextro-TGA. Dextro-TGA. We're going to come to the TGA topic beautifully. So just at least remember this much. Rushkind procedure is done in a case of DTGA. DTGA is nothing but dextro-TGA. Okay, and where do you do Norwood procedure? Norwood procedure basically it is done in the case of HLHS. It is done in HLHS. What is this HLHS? HLHS is nothing but hypoplastic. It is nothing but hypoplastic left heart syndrome. Hypoplastic left heart syndrome. It is a congenital condition. So in the case of hypoplastic left heart syndrome, the procedure which we do is Norwood procedure. It is an exam question, and this procedure basically takes multiple surgeries. It's like a step 1, step 2, step 3 surgery. Okay, because hypoplastic left heart is the normal heart, but the left side of the heart basically is hypoplastic. It is just like this. It has not formed properly. So basically to make this left side proper, we need multiple step 1, step 2, step 3 surgery. In one part I will make the left atrium, in one part I'll make the aorta, in one part I'll make the left ventricle. As it's a hypoplastic left heart syndrome, the name of the surgery is Norwood procedure. Now coming to the topic per se, the beautiful topic of the choice is TGA. Question number 1, what is TGA? So sir, TGA is nothing but transposition of great arteries. Transposition of Great arteries. Are you understanding? TGA is nothing but transposition of great arteries. What is the meaning of that, sir? I have no idea what are you talking about. Okay, I'll tell you. It's very simple. Okay, if I make this beautiful four-chambered heart, this is a four-chambered heart. We have the right atrium, we have the right ventricle, we have the left atrium, we have the left ventricle. Okay. Now, normally, this part, you know that, right? So, this part is the pulmonary artery and this part is the aorta. I assume we all know this point, right? So, transposition of great arteries. So, great arteries has been transpositioned because so this part basically becomes the aorta. Normally, it should be the pulmonary artery which connects to the lungs, but in this case, it will be aorta, and this part will be amazingly pulmonary artery. This will be pulmonary artery. Are you understanding? So this is what very important we must understand, that we have this what you called transposition of great arteries. So great arteries has been transpositioned. Okay, remember that. Okay, so now what will happen? So what exactly is going to happen, sir? What is the problem? It's okay, right, if the aorta has come to this side? No, this is not okay. Why? So see, now the deoxygenated blood, as we all know, by the superior vena cava and inferior vena cava, the deoxygenated blood, it enters my right atrium, and then deoxygenated blood, it enters the right ventricle. And right ventricle, normally it is connected to the pulmonary artery. In this case, where it is connected? It is connected to the aorta. So the deoxygenated blood entered and deoxygenated blood exited from the aorta. And aorta is, what does the aorta does? Aorta supplies the blood to the whole body. We have the thoracic aorta, abdominal aorta, and then it supplies the blood to the whole lower limbs and everywhere, right? And then normally, as you all know, that all the deoxygenated blood again enters our right side of the heart by the superior vena cava and inferior vena cava. Can we therefore appreciate one point, that the deoxygenated blood only entered the body and deoxygenated blood only leaving from the body? Again, from the aorta, the deoxy blood spreaded the whole body, and then from the superior and inferior vena cava, again the deoxygenated blood entered in our right side of the heart. Okay, this is like one side circulation is going on. As we go to the other side, very important, as we all know, that lungs, what is the function of the lungs? Purification of the blood. So lungs purify the blood normally, and then with the help of pulmonary veins, do you remember, yes or no? With the help of pulmonary veins, the oxygenated blood, it enters the left atrium. Normally from the left atrium, the oxygenated blood enters the left ventricle. Everyone knows about it, right? Oxygenated blood enters the left ventricle. From the left ventricle, normally oxygenated blood should connect to the aorta. Now in this case, where it is connecting? In this case, it is connected to the pulmonary artery. So oxygenated blood entered the pulmonary artery, and pulmonary artery is connected to what? Pulmonary arteries are normally connected to the lungs, normal connection. So again the blood is purified, and again the purified blood enters from the pulmonary veins. They are entering to the left atrium, then to the left ventricle, again to the pulmonary artery, and again back to the purified blood only entered and purified blood only left and again entered the lungs. Are you understanding? So in one side circulation, the right side, deoxygenated blood is moving in and moving out, whereas on the left side, the oxygenated blood is moving in and moving out. Now what do you call this? What is this? This is beautifully known as parallel circulation. This is known as parallel circulation. That is the first exam entrance question number 1. In which of the congenital heart disease you see parallel circulation? Means parallel as in parallel. One-sided, one circle is going, one-sided, one circle is going. There is no connection at all. It's just two circles together, but they are running parallel. This is known as parallel circulation. So where do you see parallel circulation? The beautiful answer is transposition of great arteries. Okay. Now in this one, now very important. So will the child be cyanotic in this congenital heart disease? Will the child be cyanotic? Yes or no? The answer is yes. The child will be undoubtedly fully cyanotic, because naturally, because deoxygenated blood entered and deoxygenated blood exited from the aorta, so baby will be fully cyanotic. That is why TGA is the most common. the most common cyanotic congenital heart disease, CHD, the most common cyanotic congenital heart disease at day 1 of life, it will be TGA. The most common cyanotic congenital heart disease at day 1 of life, it will be a TGA. But as in the infant or in the later age group, it will be TOF, right? What is TOF? You know that, right? TOF is nothing but tetralogy of Fallot. Are you understanding? Normally we say in the spelling it is tetralogy of Fallot, tetralogy, but we say tetralogy of Fallot. Okay, that you should know. So okay, so now last point which we must appreciate in this one, that the child will be cyanotic. Yes, fully cyanotic. So now as the child will be totally cyanotic, now one thing we have to help the child, because if you just keep the baby like this, the baby will expire, because there is no lungs and it's all bad blood or deoxygenated blood going to the whole aorta, right? So the baby will expire. So now to help the baby, basically, so you know that, right? There's something known as ductus arteriosus. Yes or no? Have you heard of ductus arteriosus? Over here, ductus arteriosus, which is between the pulmonary artery and the descending aorta. We all know that. If I keep this ductus arteriosus open, if I give some drug, you know that, right? We have a drug known as L-prostadil. It is a PGE1 analog or a PGE2 analog. It is prostaglandin PGE1 analog, L-prostadil, which will keep the ductus arteriosus open. It's an exam question. L-prostadil is one medication which keeps the ductus arteriosus open, right? So now one thing we must appreciate, that now see, the oxygenated blood from the lungs, it basically enters the left atrium, then it enters the left ventricle, and from the left ventricle it enters the aorta. In this case it enters the pulmonary artery. So as we all know, ductus arteriosus is a left to right shunt. You know that, right? Because the left side of the heart has a higher pressure. So if I open this defect, basically the flow of this defect will be anyone left to right or left to right to left. It will be exactly from left to right. Are you understanding? So that's what the blood from the ductus arteriosus will enter my descending aorta, and from the descending aorta it will be supplied to the whole body. Can we therefore appreciate this beautiful point? Can we see, can I say that I am doing the mixing of the blood? This mixing of this blood, if I intentionally keep the ductus arteriosus open, will it be helpful for the baby or it will be not helpful for the baby? Can anyone answer me? What do you think, bro? It will be helpful, it will not be helpful? So the best answer on this planet will be yes, it will be very, very, very helpful for the baby, because you are mixing the oxygenated blood in the deoxy, right? Otherwise it was only deoxygenated blood moving on and the patient was fully cyanotic. But now it is very helpful if you keep the ductus arteriosus open. So that's it. So now this is a very important question. Now this is known as duct dependent congenital heart disease. This is known as duct dependent congenital heart disease. Means you are dependent on the duct for the survival of the baby. If you don't keep the ductus arteriosus open, the baby will die, the baby will expire. So TGA is a very important 3 marks and 5 marks question for our theory paper, that names some duct dependent congenital heart. So TGA is one of the very important duct dependent congenital heart disease, where I'm dependent on the ductus. Okay, I'm dependent on the ductus arteriosus for the survival of the blood, for the survival of the baby. Okay, so this is what very important point we must appreciate. This part is over. So again, what do you think? Is it a cyanotic congenital heart or a acyanotic congenital heart? It is a beautifully cyanotic congenital heart. Just now we spoke about it, right? The most common cyanotic congenital heart at day 1 of life is TGA. Otherwise, later period it will be TOF. Okay, and TGA is the most specific congenital heart disease in which condition? So very beautifully we have done something about IDM. What is IDM? IDM is nothing but infant of diabetic mother. IDM is nothing but infant of diabetic mother. So the most common congenital heart disease, in infant of diabetic mother is a VSD. What is a VSD? VSD is a ventricular septal defect. VSD is a ventricular septal defect. Are you understanding? The most common congenital heart disease in infant of diabetic mother will be a VSD, but most specific That's what it's written. Most specific will be a TGA. The most common congenital heart disease in infant of diabetic mother will be a VSD. The most specific will be TGA. That you should know. Okay, a very important exam question. Okay, this part is done. Okay. And what are the? How do you classify TGA? This is very important. TGA, the full theory, everything I've told you. Okay, so TGA basically it is classified into two things: TGA with an intact ventricular septum or TGA with a VSD. Now listen very carefully. Listen very carefully. See, four-chambered heart again. Okay, and again, very importantly, this becomes the aorta and this becomes the pulmonary artery in a case of transposition of great arteries. So see, always remember one thing, TGA. See, always remember the congenital heart disease, they are always associated with some other defect. Congenital heart disease per se, if I talk about any congenital heart, they are always associated with some other defect. God, the nature has done such a role that alone TGA, the baby can't survive, right? If I say this point, TGA with an intact ventricular septum, this ventricular septum is intact, it's not defect, right? TGA, and the patient has TGA, so the baby will have fully cyanosis, yes or no? The baby can expire also. It is like a big problem. PDA, so if I say PDA open, that is to my choice, no? That is my choice to keep the PDA open. That like the baby will be born out and this and that. Then I will see. Then I will think of giving 𝐿-prostadil. Then it will keep the PDA open. PDA opening is my choice. But TGA with the intact VSD, and also the classification we have TGA with a VSD. TGA with a VSD. So again, can we appreciate this point? God has beautifully made this associated defects. If you do not make this associated defect, the baby will die. VSD is same like PDA only, no? If I keep the VSD open, same it is a left to right shunt, same the oxygenated blood is coming and mixing with the deoxygenated blood and helpful. It is helpful for the baby. Same was in the case of PDA, right? It's just that PDA is something that I gave from outside. I gave the drug to keep the PDA open. But if I don't give the drug, that God has already made, you know, the defect TGA with a VSD. TGA with a VSD. Are you understanding? It's a very beautiful concept. So that's what. How do you classify TGA? TGA with the intact VSD and TGA with the what you call the VSD, ventricular septal defect. Okay, it's a very beautiful point. Please remember. Next, which is the best mixing site in case of TGA with the intact ventricular septum? Which is the best mixing site in a case of TGA with the intact ventricular septum? Again, if it is a four-chambered heart, this is very importantly, this is our aorta and this is our pulmonary artery. So VSD, which is the best mixing site of TGA with the intact ventricular septum. Here the septum is totally intact, okay, there is no problem, and the patient has TGA. And PDA also is closed, okay. PDA is something I am doing it, right? But if PDA is also closed and VSD is also closed, which is the best mixing site? Are you understanding? Mixing has to happen. The baby will die. Do you agree with me? Yes or no? Baby will die, no? Mixing has to be there. PDA, I was doing the mixing. VSD, okay, fine. If there is a defect, it's very good for the mixing. If PDA not available, VSD not available for the mixing, then which is the best mixing site available? So the beautiful answer for this one will be foramen ovale. Foramen ovale will be the best mixing site in case of TGA with a intact ventricular septum. You remember foramen ovale? This one here, you have the foramen ovale, okay, foramen ovale. So same like a foramen ovale over here, foramen ovale will be a best mixing site naturally, you know, same thing, VSD, foramen ovale or PDA. If PDA not available, then VSD. If VSD not available, then the site will be foramen ovale for the best mixing site in a case of TGA. That you should know. Okay, perfect. I hope you guys agree. It's a beautiful topic, very amazingly we are covering it. So, okay, and also remember TGA is associated with uncontrolled phenylketonuria in the mother. Okay, we're going to talk about inborn errors of metabolism. Just this one message you understand: if the mother has phenylketonuria, if the mother is suffering from phenylketonuria, her baby can have TGA. So TGA / phenylketonuria / mother. If the mother has phenylketonuria, the baby can have TGA. It is that way. Is associated. One thing, this point you must remember. Okay, this part is over. So we have done all the amazing parts we have done. Okay, and also Rushkin procedure, I told you just now, Rushkin procedure is done in dextro TGA, Rushkin procedure. This is one important point. And yeah, and which is the most common congenital heart disease in cardiology? We know this point, right? We have done this in the previous classes. The most common acyanotic congenital heart disease in cardiology will be a ventricular septal defect. And the most common cyanotic congenital heart disease on day 1 will be TGA. In older children, it will be TOF that we have done. And if I say the most common congenital heart disease in full cardiovascular system, like I'm not mentioning acyanotic, I'm not mentioning cyanotic, I'm just asking you which is the most common congenital heart disease in cardiology. So the answer is VSD. VSD is the most common what you call congenital heart disease in cardiology. Okay, that you should know. Okay, this part is done. So we have very beautifully covered the topic amazingly, you know. Okay. So, okay, let's see if anything else is left. Yeah, this is a good point. So, chest X-ray. We cannot finish this topic without discussing the chest X-ray in a case of TGA. In a case of TGA, very important, chest X-ray plays a very important role. And this is something egg on string appearance. Very, very important. You will see egg on string appearance. So, it's a very important finding. You must appreciate the chest X-ray finding in a case of TGA is egg on string appearance. And where do you see boot-shaped heart? Anyone? Boot-shaped heart, it is seen in tetralogy of Fallot. Boot-shaped heart is seen in tetralogy of Fallot. Where do you see box-shaped heart? Box-shaped heart, it is seen in Epstein anomaly. Box-shaped heart, it is seen in Epstein anomaly. And where do you see Schmoo sign? Schmoo sign. Schmoo sign is seen in it is seen in left ventricular hypertrophy, LVH. Okay, so Schmoo sign is seen in left ventricular hypertrophy. Box-shaped heart is seen in Epstein anomaly. Boot-shaped heart, it is seen in tetralogy of Fallot, and egg on string appearance, it is seen in TGA. It is seen in TGA. Okay, so now very importantly, yeah, this is very easy part is over. Yeah. Now this is one thing you remember. I told you, right? TJ with the intact intact septum and TJ with VSD. So patient with TJ with intact septum. The septum is intact and the patient has TGA. Will the patient be cyanotic at birth? One second. One second. Yeah. So yeah. One second. Yeah. Will the patient be cyanotic at birth if the patient has a TGA with the intact septum? So yes, obviously TGA with intact septum, yes, the patient will be cyanotic, and the patient will show you the signs of congestive heart failure by the first week of life. This is very important. Within 0 to 7 days of life, within first week of life, the TGA patient will show you symptoms of the failure, the TGA with the intact septum. But if I talk about TGA with a VSD, if I talk about TGA with a VSD, then the cyanosis will be mild. Do you agree, yes or no? Because VSD is open, the left side oxygenated blood is mixing with the right side, and that's why the baby is feeling better. So yeah, so number one, the cyanosis will be little mild, and number two, the feature of congestive heart failure, when are you expecting to see? So 6 to 8 weeks of life. 6 to 8 weeks of life. Some book says 4 to 10 weeks also. So 6 weeks as in 1.5 months. 6 weeks is 1.5 months. So please appreciate 1 week and 1 month. Okay. If a TG with the intact septum, then the failure features will come within 1 week of life. TG with the VSD, then naturally 1.5 months it will take for the baby to come to you with signs of congestive heart failure or a complicated case, right? Naturally, you know the answers, right? Okay, great. This part is done. Okay, and yes, of course, just now I told you keeping the PDA open will be helpful in this case. To open the PDA, we give prostaglandins of 2 types, PGE1 and PGE2. PGE1, the drug of choice is L-prostadil. The drug of choice is L-prostadil, very, very important. And for PGE2 is endogenous. PGE2 is endogenous. Placenta secretes PGE2. Placenta secretes PGE2, which keeps the PDA open. Placenta secretes PGE2, which keep the ductus arteriosus open, and PGE1 is L-prostadil. We give intravenous through infusion pump. Okay, that you should know. And the last but not the least, what surgery do you want to do in this case? Very, very important. Let me just tell you. Now there is something known as, now listen very carefully. If this is the 4-chambered heart, okay, very simple it is. This is our what we call the aorta, and this is the pulmonary artery. So this is the right atrium, right ventricle, left atrium, left ventricle. Now listen very carefully. So once the deoxygenated blood enters the right atrium, I will connect the right atrium to the left ventricle. This is the first connection. Where the, very importantly, right atrium is connected to the left ventricle. So imagine the deoxygenated blood from the right atrium, it reaches the left ventricle. From the left ventricle, it will go to the pulmonary artery, obviously, and pulmonary artery are connected to the lungs. Basically, everyone knows about it. And from the lungs, where does the oxygenated blood goes? With the help of pulmonary veins, it enters the left atrium. So now again, I will connect the left atrium with the right ventricle. You will connect the left atrium with the right ventricle. So now the oxygenated blood from the left atrium enters the right ventricle. From the right ventricle, it enters the aorta, and from the aorta, the oxygenated blood beautifully supplies to the whole body. And once it supplies to the whole body, then again it enters the right atrium. From right atrium to left ventricle, to pulmonary artery, to lungs, to left atrium, to right ventricle, to aorta, and to the whole body. Now this is known as, very importantly, which switch we call it? This is known as arterial switch, and the name of the surgery is Jet-knee repair. Jet-knee repair. The name of the surgery is Jet-knee repair. The switch is known as arterial switch. This is a definitive surgery. So it's an exam question. Definitive surgery of choice in a case of TGA is nothing but Jet-knee repair. An emergency procedure, if you want to do, you will do a balloon atrial septostomy. If emergency procedure you want to do, you will do a balloon atrial septostomy. If just you want to do a definitive surgery, then Jet-knee repair sounds a good option. Jet-knee repair sounds a good option. This is very beautiful point of our TGA. Okay. And TGA, will you see plethoric lung fields or oligemic lung fields? You know that, right? Plethoric lung fields means increase pulmonary blood flow. Plethoric lung fields means increase pulmonary blood flow, and oligemic means decrease pulmonary blood flow. So if I talk about TGA, this side was the aorta and this side was the pulmonary artery, and pulmonary artery are connected to the lungs. So I am saying that will you have an increased pulmonary blood flow, decreased pulmonary blood flow? So as you know, from like the oxygenated blood from enters into the left atrium and then into the left ventricle and then into the aorta. So much of oxygenated heavy blood, no, good quality blood is there. So the patient will have kind of increased pulmonary blood flow. So you will see plethoric lung fields in a case of TGA because the content, the quality of the blood is oxygenated. It's like more heavy, more fast, more crazy blood will go. So increased pulmonary blood flow, you will see nothing but plethoric lung fields. Okay, this part is over. And I've told you already, Norwood procedure is done in HLHS, hypoplastic left heart syndrome, and that's it. That finishes this part. That finishes this beautiful class, guys, on TGA. I hope you have understood beautifully. So thank you so much, everyone, for this wonderful participation. And remember, you are the only architect of your life. You are the only architect of your life. So better do something amazing with your life. Make your life crazy. Make your life amazing. Okay, and be happy. Life is really beautiful. My mobile number is 9999897081, and this is our WhatsApp group and Telegram group we have for the recent one-liners and recent updates in pediatrics. If you wish, you can join, and you can ask me any doubt in the group, and that's it. Thank you so much, everyone. Please take care and have a wonderful evening ahead. We are finishing the cardiology now. It's just 1-2 topics are left, and then we'll finish everything nicely. Okay, thank you. Bye. Hello everyone, welcome to Pediatrics by Dr. Anand. In this beautiful segment, we're going to talk about a very important topic of cardiology. Today, we're going to talk about differential cyanosis, reverse differential cyanosis, and some other important questions of cardiology. I hope you're liking the videos. Every single video has been made with a lot of good intention. I hope you guys are liking it. Before starting any amazing segment, we always have a motivating quote, and today's motivating quote is, change is never painful. Change is never painful. Only the resistance to change is painful. A very meaningful quote. Change is never painful. Only the resistance to change is painful. See, change is a part of life, time flows, people change, we change, everything changes. Change is never painful, but the resistance to change is painful. We always say, that we never want to come out of our comfort zone. We all have a comfort zone and we never want to come out of our comfort zone. But it is very important to come out of your comfort zone, because then only you can see the ups and downs of life, and you can be a better person basically. So don't be in your comfort zone. Accept the change. Change is okay. Change is not painful. The resistance you show to the change, that is painful. So be amazing, be just mind-blowing and you are perfect. Always remember, I've told you, you are the only architect of your life, so better make something amazing about your life. Okay, you are just amazing, self-sufficient, and you have got everything. Today's topic of choice, we're going to talk about something known as differential cyanosis and reverse differential cyanosis with one example of each. The meaning of differential cyanosis, which we must understand: differential, L for differential, L for lower limbs will be more cyanosed than the upper limb. There are some congenital heart defects where the lower limb of the child will be more blue than the upper limb. So when the feet are more blue than the hands, that is known as differential cyanosis. Very important. And opposite of that is reverse differential cyanosis. In reverse differential cyanosis, upper limb will be more cyanotic than the lower limbs. And one example is important. For the example of differential cyanosis where the lower limbs are more cyanotic than the upper, the example is PDA with a reversal of shunt. The beautiful example is PDA with a reversal of shunt. So we know that this is a beautiful 4-chambered heart, which we know, and also we have multiple times we have discussed this topic of PDA. So this one is nothing but PDA, which is a left to right shunt. Very important. So PDA with the reversal of shunt, in this condition the lower limb will be more cyanotic than the upper limbs. Why? So whenever there is PDA is a left to right shunt. We have done this before because the left side of the heart has a higher pressure. So naturally, if the defect of PDA is open, the direction of blood of flow will be left to right. That is the first point. Second point, so naturally when the PDA is a left to right shunt, then naturally can we appreciate that more and more blood will flow through the pulmonary artery? Yes or no? Because normally the blood is coming from the right atrium to right ventricle to pulmonary artery, normal flow, and in the PDA from the left side of the heart to the right side to the pulmonary artery. So that is nothing but leading to increased pulmonary blood flow. Increased pulmonary blood flow. Are you understanding? So whenever there is more left to right shunt, there will be increased pulmonary blood flow. When too much of blood flow increases through the pulmonary artery slowly goes to damage, leads to pulmonary obstruction. You know, naturally on a traffic, when you have on a road, when you have too much of traffic, the road starts to get damaged. When you have too much of pulmonary blood flow, the pulmonary artery slowly goes into fatigue or obstruction or stenosis. So nothing but leads to pulmonary stenosis. So when this part will be totally blocked or pulmonary obstruction or stenosis, the flow of the blood which was from left to right, now it is from right to left. That is what reversal of shunt. That is the reversal of shunt. So now I'm saying in a case of PDA with a reversal of shunt, the lower limb will be more blue than the upper limb. So why lower limb will be more blue? Listen carefully. So now as we can appreciate, very important point, that in a case of what we called PDA, now what is the flow of the blood? We know that now it is right to left. Now it is right to left. So as we all know, from the lungs, the oxygenated blood enters the left atrium, then it enters the left ventricle. Naturally, the oxygenated blood from the left ventricle, where does it go? It goes to the aorta. This is nothing but the aorta, right? It goes to the aorta. This is the pure oxygenated blood. So before this mixing, before touching the ductus arteriosus, before this mixing of the blood moves here and there from the right to left, this mixing of the blood, aorta gives separate branches. Aorta gives two separate branches, which are very importantly nothing but the right brachiocephalic trunk and the left brachiocephalic trunk. Are you understanding? This is the aorta. So once the aorta, the blood is flowing, this part is the, as you can see, this is the ductus arteriosus. So before touching this channel, before this mixing of the blood point, before that only, the aorta is giving a right brachiocephalic trunk and a left brachiocephalic trunk, which basically supplies our right and left upper limb, right and left upper limb. So can we therefore appreciate this point? Before the mixing, before the touching of the ductus channel, this blood coming from the aorta, is this the oxygenated blood or the deoxygenated blood? So very beautifully everyone knows about it. This is the pure oxygenated blood. Are you understanding? from the left atrium to left ventricle to the aorta. Before the mixing, the aorta giving branches to the right brachiocephalic trunk and the left brachiocephalic trunk, which gives supply to the upper limb. So upper limb blood will be kind of acyanotic, and then the mixing is happening. Are you understanding? Then from the ductus arteriosus, the blood is going to the aorta, as we are speaking about right to left shunt, because reversal of shunt was there. Are you understanding? So what is this? Like, this is nothing but our, see, this is the pulmonary artery, and what is this? This is the ductus arteriosus. What is this? This is the aorta. Are you understanding? So that's what you need to understand the whole concept. That is why the upper limb, basically the blood will not be cyanotic, and lower limb will be more cyanos than the upper limb. This is known as, this only is known as, very importantly, differential cyanosis, when the feet are more blue than the hands. That is one important example of PDA with a reversal of shunt. Is an example of differential cyanosis. Then next question we had is very important. What is reverse differential cyanosis? Yes, now this is important. In the reverse differential cyanosis, the upper limb are more blue than the lower limb. This is very important point. In a reverse differential cyanosis, upper limb are more blue than the lower limbs. Lower limbs. Okay, are you understanding? So again, now what is the congenital heart disease? Like, in which condition do we see the upper limb are more blue than the lower limbs? Very importantly. So one example you must know: TGA with portal hypertension, TGA with pulmonary hypertension. This is one very beautiful picture, very beautiful example of reverse differential cyanosis, where the upper limb will be more blue than the lower limbs. Now again, a question: why? You must understand yourself why. You must ask yourself why this is happening. Now remember one thing. Yes, so as you know, very importantly, this part, okay, not TGA. You know what is TGA, right? Anyone, what is TGA? TGA is transposition of great arteries, yes or no? This is the right atrium, this is the right ventricle, this is the left atrium, this is the left ventricle. So this one, this is normally should be the pulmonary artery. In a case of TGA, this is the aorta and this is the pulmonary artery. Are you understanding? This is only TGA, right? Transposition of great arteries, great arteries. Now listen very carefully. TGA with pulmonary hypertension. Number one, TGA has happened, like right side is aorta and left side is pulmonary artery. With pulmonary artery hypertension, as in pulmonary artery hypertension, indirectly I am trying to say that this part is blocked. This part is blocked. Are you understanding? Indirectly I'm trying to say that this part is totally blocked, obviously, right? Pulmonary hypertension, right? Yeah, so now I'm saying that TGA is in front of me, pulmonary hypertension is in front of me. In this case, the upper limb of the baby's body will be more cyanotic than the lower limb. Why is such a case? Okay, it's very easy. Now listen very carefully. TGA with pulmonary hypertension. As you know that ductus arteriosus, like it's a duct dependent congenital heart. No, we need ductus arteriosus for the survival of the blood. So this is ductus arteriosus, right? And if you're a newcomer, we have done the previous videos on TGA. Watch the whole video of TGA. It will be helpful for you. So now from the lungs, oxygenated blood enters the left atrium naturally. From the lungs through the pulmonary veins, oxygenated blood normally enters the left atrium, then it enters the left ventricle. Then it should enter the pulmonary artery, but I was told that there is a pulmonary hypertension or pulmonary stenosis kind of a thing. So then where the blood will go? The blood from the pulmonary artery, it will go to the ductus arteriosus and then to the descending aorta, You know, right? PDA is between what and what? Patent ductus arteriosus is between the pulmonary artery and descending aorta. So now can you please tell me the blood which is entering the ductus arteriosus through the left ventricle and pulmonary artery, is this the oxygenated blood or the deoxygenated blood? I think everyone knows about it. This is the pure oxygenated blood, right? This is the oxygenated blood. So oxygenated blood enters the patent ductus arteriosus and then it enters the descending aorta. So now this, as it enters the descending aorta, it supplies to the whole lower limbs. So point number one, lower limbs will not be cyanotic because it is getting pure oxygenated blood, right? I said upper limb will be more cyanosed. Why? The beautiful reason for that is that this mixing point is there. No, before this mixing point over here, aorta gives the branches. Just now I told you, right brachiocephalic trunk and left brachiocephalic trunk. Do you remember that? It is proximal to the ductus arteriosus. Are you understanding? I just now showed you the diagram also, that right and left brachiocephalic trunk, they are proximal to the ductus arteriosus channel, right? That is why which blood this right and left brachiocephalic trunk will get? They will get the deoxygenated blood, because they are getting blood from the superior vena cava to the right atrium and right atrium to the right ventricle. So superior vena cava to right atrium to right ventricle to the aorta. So aorta, through the aorta, are you understanding? It's giving a right and left brachiocephalic trunk, which is basically giving you a deoxygenated or a cyanotic blood. That's why upper limb will be more cyanotic than the lower limb. Now this is a very beautiful point known as reverse differential cyanosis. And I want you to remember one more thing, that what you called the other condition, the reverse differential cyanosis, other than TGA with pulmonary hypertension, you can also see in DTGA with the VSD. DTGA as in dextro transposition of great arteries with a ventricular septal defect, severe coarctation of aorta, and supracardiac TAPVC. These four conditions, remember, you will see reverse differential cyanosis. TGA with pulmonary hypertension, DTGA with a VSD, severe COA, and supracardiac TAPVC, reverse differential cyanosis. Next question, Karnataka exam, it had come. A child born to mother with SLE are likely to have one of the following anomalies. If the mother has born with SLE, systemic lupus erythematosus, do you remember that systemic lupus erythematosus? We have done this class before. SLE, systemic lupus erythematosus, point number 1. And point number 2, what kind of rash do you see in a case of SLE? The mother will have a butterfly rash. The mother will have a butterfly rash, okay, and a butterfly rash over the face. Is like a butterfly, like that, okay. It's like a butterfly rash, seen in SLE. If the mother has SLE, the baby can have one big problem. The baby can have a complete heart block. Please remember, the most common congenital heart problem the baby can have is complete heart block in a case of SLE. If the mother is having SLE, that you should know. This part is done. Again, a quick motivating quote: don't prove yourself, okay, improve yourself. Don't prove yourself, just improve yourself, okay. There is always a room for improvement. Tell yourself you are an amazing soul, and if you have to improve, you will improve. Don't be, don't get bitter, be better. Don't be bitter, be better. People should love you the way you are. No, they should not be like, oh my god, this fellow is so irritating, oh my god, this fellow is so short-tempered. So that shouldn't happen, right? That you should. Okay, very good. Next is a very beautiful topic. Next topic we have is TAPVC. TAPVC. What is TAPVC? I think everyone knows about it. TAPVC is nothing but total anomalous pulmonary venous connection. Total anomalous pulmonary venous connection. It's a very beautiful topic, very easy topic. Okay, total anomalous. Total anomalous means totally wrong. What is wrong? Pulmonary veins connection. So as we all know, from the lungs we have the pulmonary veins, right? From the lungs, pulmonary veins normally enter where? From the lungs, the oxygenated blood is carried by the pulmonary veins, and they entered the lung, they entered into the left atrium. This is a normal thing. This is a normal thing. Everyone knows about it, yes or no? Do you know that? Yeah. And you know, right, this over here we have the basic superior vena cava, we have the right atrium and superior vena cava, and even over here we have inferior vena cava also. You know that, right? Superior vena cava and inferior vena cava, they enter the right atrium. So the topic is total anomalous, means totally wrong. What is wrong? Pulmonary veins connection. Pulmonary veins, which normally should enter the left atrium, these pulmonary veins can enter by mistake wrongly in 3 different locations. The pulmonary veins can get connected to the superior vena cava, number 1. Either the pulmonary veins are getting directly connected into the right ventricle, or they can get connected into the inferior vena cava. So superior vena cava, right ventricle, and inferior vena cava. So this is like totally wrong. What is wrong? Pulmonary veins connection. Pulmonary veins are normally, they should connect into the left atrium, but here they are connecting either into the SVC or RV or IVC. If the pulmonary veins are getting connected into, very importantly, the superior vena cava, this superior vena cava, this is known as supracardiac. This is known as supracardiac TAPVC. Supracardiac TAPVC, supracardiac total anomalous pulmonary venous connection. Are you understanding? Supracardiac means above the heart. Can you see that supracardiac? The pulmonary veins are getting connected into the superior vena cava. So that is a supracardiac TAPVC, like just above the heart. Okay. If the pulmonary veins are getting connected into the right ventricle, this is known as cardiac TAPVC. If the pulmonary veins are getting connected into the inferior vena cava, that is known as infracardiac TAPVC. So we have three types of TAPVC: supracardiac, cardiac, and infracardiac. So exam entrance question number 1, which is the most common among these three, supracardiac, cardiac, or infracardiac? The answer is the most common type of TAPVC is supracardiac TAPVC, number 1. Which is the most obstructive? Which is the most obstructive type of TAPVC? Which is the most obstructive type of TAPVC, or I would say surgical emergency? I would say surgical emergency. So the answer is infracardiac TAPVC, because infracardiac TAPVC is also known as obstructive TAPVC. So because when the pulmonary veins are getting connected into the inferior vena cava, no, it's like it's a very long course, and it's gonna be a very bad for the baby. So the most common TAPVC is supracardiac, the most obstructive is infracardiac, and very important, X-ray. Which is the X-ray finding do you see? Remember, X-ray finding in a case of supracardiac TAPVC, I want to show you very important. There is something known as, yeah, this one. This is known as figure of 8 appearance. Figure of 8. So where do you see figure of 8 appearance? So figure of 8 appearance is seen in supracardiac. Please remember, it is supracardiac. Yes, it is supracardiac TAPVC, that you should know. Okay, not just cardiac or infracardiac, it is supracardiac. Okay, it is supracardiac TAPVC, figure of 8 appearance. And where do you see figure of 3 appearance? We have done this before. Figure of 3 appearance you see in coarctation of aorta. In a case of coarctation of aorta, we see figure of 3 appearance, and figure of 8 appearance you see in supracardiac TAPVC. And also it is known as snowman's heart. I'll show you one more picture. Yeah, this one is nice. So very importantly, snowman's heart, this one, you know, igloo sign, that snowman we make in the winter time. So snowman's sign or snowman's heart or snowman's sign is nothing but, or figure of 8 appearance, like, you know, it's like a 8, figure of 8 appearance is seen in supracardiac TAPVC. And remember, infracardiac TAPVC will present to you as this ground glass appearance. Very important, ground glass appearance, very important. Or you can say white out lung. So white out lung, if white out means, as in, can you see that normally what should happen? Normally, if this was a good lung, you would have seen a nice black color, right? That black lung you would have seen, and this would have been the heart. It should be very black, right? This is like very whitish. So this is a white out lung. So white out lung is seen in multiple conditions, but at least one you should remember. One is the infracardiac TAPVC, and another one is HMD. Exactly. What is HMD? Can you please tell me? We have done the neonatology whole course, hyaline membrane disease. HMD is nothing but hyaline membrane disease. Okay, hyaline membrane disease, or it is also known as respiratory distress syndrome. It is also known as respiratory distress syndrome, HMD. So white out lung is seen in HMD or RDS, and also it is seen in infracardiac TAPVC. Supracardiac TAPVC, you will have a figure of 8 appearance. And what's the treatment for this? The treatment for this beautiful condition is pulmonary venous rerouting. The topic is that only, you know, total anomalous, totally wrong. What is wrong? Pulmonary veins connection. So pulmonary veins rerouting will be a very good idea. That covers a very beautiful part on the TAPVC. Very beautiful topic we have covered, and it's amazing. So I hope you guys are really liking the videos, and this is now beautiful. The cardiology is now coming to an end. Like, we have just 1 or 2 topics left. Okay, and again, before leaving, again a very important motivating quote. And what is the motivating quote? Motivating quote is this, bro: success, you know, success basically, which everyone look at you, oh my god, he has a BMW, oh my god, they have such a good car, yeah, they're so lucky, they have such a huge house. So this is the success you see, right? But what is behind this success? Disappointment, persistency, hard work, risk, late night, competition, discipline, courage, doubt, criticism, failures, adversity, and rejections. This whole, iceberg is known as iceberg phenomenon. As in, you just see the tip of the ice, but the reality, the whole thick ice is inside the water. So we all are working really hard, and I know you guys are working so amazing, so hard work. You're doing it, all right. So that's what. So enjoy the fruit, enjoy life. Life is so beautiful. Just enjoy, breathe, like be happy for no reason. Just smile. Right now, also you're looking at the video, right? You're looking at me. Just smile one time. Just smile like this, like this, like this. Yes, yes. हैप्पी जिंदगी भगवान की एक बहुत महंगी गिफ्ट है लाइफ इज द मोस्ट एक्सपेंसिव गिफ्ट द गॉड हैज गिवन यू सो ईदर यू कैन यूज इट इन वेरी वेरी डिस्ट्रक्टिव वे or you can use it in a very constructive way. You can you can read novels, you can go for movies, you can play badminton, you can play rugby, you can be the best in your class, you can do anything, bro, anything, you name it and you got it. It's as simple as that. There is nothing you can't achieve. Even a blind person also can do really good. So there's nothing you can't achieve. Everything is in you, and you have got this. That's it. Thank you so much, everyone, for this wonderful participation, and I had a good time. I hope you learned something. And now, in the further classes, we're going to talk about Epstein anomaly, tetralogy of Fallot, and acute rheumatic fever and rheumatic heart disease. Very simple, beautiful topics. We will cover it. Thank you. Please take care, and bye bye.